Let's hear about the escapes in BPH, the good, the bad, the ugly, from Dr. Gilling. I'm so glad that he's been willing to come this far to come talk to us. And yesterday when we had the whole up CME, it's been very interesting to see the progress and where we're going with BPH care. It's my great pleasure to introduce Dr. Gilling, the Clinical Campus Dean in Faculty Medicine, Health Sciences at the University of Auckland, New Zealand, and head of the Bay of Plenty. I love that name. Clinical Campus. Welcome, Dr. Gilling.
And thank you, President Meady. If that's your correct term. So yes, this is a bit of a reflection in some ways, and also just to show you some of the new things that are out there in terms of BPH gadgetry that are being tested currently. And I was hoping to be piped into the music from this movie because I don't know if you remember it, the one with the whistling. Yeah. The name of that tune is The Ecstasy of Gold. And that's very important when it comes to this sort of thing, because we were just talking before about, we all remember how Neotract was sold for $1.1 billion to Teleflex a few years ago. There is definitely gold in those hills. But we also saw yesterday in that paper that I showed in the first couple of slides that there are a lot of failures. There are a lot of these devices never make it to market. And I think the capitalized cost per successful device was something like $522 million, and that was in 2018 dollars. So it's an interesting space. So this is really just a bit of a mishmash of devices that I've been involved in. Not exhausted by any means, because some of them, such as thermotherapy and microwave, we used for a while, but that's still alive and well. That's just been grumbling along. None of the iterations of lasers or other techniques, I won't cover those. But these are some of the companies that are still alive and well who are relevant to this talk: ProArc, Rivermark, ZenFlow, and Prostacare. And so some of these devices are good, some of them are bad, and some of them were ugly, and I'll tell you which ones are which. These are the ones I'm going to cover. I'll just talk briefly about the bipolar gyrus probe, which was an interesting diversion. One of the ugly ones was ethanol ablation. We'll talk about that momentarily. I'll tell you about an interesting device, the Cosman radiofrequency device, and then we'll look at some of the more current treatments that are currently in the process of being investigated. Prostafix started out good, then it went bad, and then its most recent iteration was positively ugly. I'll tell you how that's been resolved. And then 3 of the newer stents, and they're different levels of complexity. It's going to be interesting to see what survives and what doesn't. Resurge is an interesting one. It's cytotoxic pellets into the prostate. And then we'll finish with robotics for BPH, robotics to do HOLEP. So it's sort of like full circle from the very first talk from the HOLEP course yesterday. Andromeda would be a good way to finish. So we'll just work our way through those. The gyrus bipolar, I only put that there because it's one of the ways of enucleating, which is possible, but shouldn't be done. And it's basically a bare probe. You know, with the gyrus device, the bipolar device, it's basically the return electrode and the active electrode are very close together, and so you can actually just use it like a bare laser fiber. We trialled this some 20 years ago, and the thought was that this might be another alternative to HOLEP, and we were looking at other energy sources to enucleate with back then. The only trouble with this was it glowed bright orange, and there was a stream of bubbles, much like the high-powered thulium laser. And really, the only people who could utilise this were people who were very experienced holmium enucleators. It was positively dangerous in the hands of people who couldn't enucleate, so you couldn't learn with it. And fortunately, it's never gone any further. So that's quite pleasing. So I would put that maybe in the bad category. Not necessarily. I'm sure there are other things that it could be used for, but not for enucleation safely. We were able to keep the gyrus generator a little bit longer, and we did do a enucleation versus TUR plasma kinetic bulbar study and bipolar study, and we did report it but never published it, and basically just showing that you could do it and it had the benefits of enucleation compared to TURP, but basically the procedure itself, the data doesn't tell the full story. So this is the one I wanted to really start on, which is transurethral ethanol ablation of the prostate. And so this was a device called the Prostafix device, not Prostafix, Prostaject. And essentially it was a delivery tool, really, and it was developed by an Indian chap who sold it to AMS, and they were organising these various trials, and I was one of the principal investigators in the global study called the GETS study. We did report our cases in a few different places. These are all abstracts, none of these are papers, but just to show that we did report it at the EAU, the Endourology meeting, and at the AUA. The only problem, well, there were two problems with this. The first was that there were a number of people who had very bad outcomes, and there was at least one cystectomy in the study that we were involved in a UK patient because of bladder necrosis. Unlike something like Resume, where the steam stays sort of confined to the prostate, the alcohol doesn't really respect the anatomic boundaries, and it was able to extravasate in under the trigone. And so that was the first thing. And the second thing is when it came to regulation, I think the FDA demanded that the study that was done was a pharmaceutical type study with thousands of people on each arm. And this is just a little, all they're trying to sell is this little plastic sort of delivery tool. So consequently they dropped it like a hotcake because there was, and also there was already knockoff devices appearing in the market. So yeah, it was basically abandoned by AMS, and there was only really one study that was ever published on the methodology, and this was it in European Urology in 2004. And you can see we do get the required 50% drop in IPSS, and we can see the obligatory 3 or 4 mils per second of improvement in Qmax, just like. This could be Urolift data, this could be Resume data, this could be ITIN data. But unfortunately, in their study as well, they had 2 patients with bladder necrosis. One went on to urinary diversion, and another one went on to reimplantation. So that's definitely wound up in the ugly basket, and was one of these many failures in terms of the proportion of these studies that don't make it through the evaluation process. This is an interesting one. This was a device that was called the TrueCath, and it was that stands for transurethral catheter radiofrequency ablation device. And this was a radiofrequency device which was very simple. It was created by a company called Cosman Medical. Now, Cosman Medical were very interesting because the chap Eric Cosman is sort of like the godfather of radiofrequency in medicine, particularly in neurosurgery and other aspects. And he started life as a professor of physics at MIT, and then after working for 20 years, he started out in nuclear physics and then became interested in radiofrequency. And then he took over a company called Radionics from his father, who subsequently sold to Tycho, so they were cashed up. And then 4 years later, he formed a company called Cosman Medical. And this was one of their, shall we say, their offspring. the company that we were involved in, the CRO that I mentioned yesterday, Avania, was working with him on another device, and he said, well, I'm thinking of looking at BPH. And so he came up with the TrueCath. And the TrueCath's a very simple device, very cheap to make and very basic. And really all it is 2 active electrodes, about 15 millimetres long, separated by 4 millimetres of catheter. You can see in that bottom diagram. And there's those little bands. You see the black and the white band. They are just optional insulation bands. So if you want a lesion that's say 30 centimetres of long, you take off all those bands, and the surgeon does this at the start of the case. You just peel them off, and then you heat the. And then if there's 2 active rings, then you heat the first one, and then it goes through its sort of cycle, which is holding it at 70 degrees for 3 minutes, and then you do the other one, and then the patient leaves. And this was done under general anaesthesia, and it was a very simple little box. And as you can see there, temperature, time, impedance, and power, and very simple, very cheap. And this is the sort of shape of the lesion that was formed. And they've done an inordinate amount of work on the shape of these lesions and various things from the radio frequency and many other specialties. And as I say, that's the catheter you can see there. But so that would be 10 millimetres for the top one, for the one on the right, and 5 millimetres for the left. So that would be a prostate that may be measured 2 centimetres or 2.5 centimetres. You might choose that configuration. And that's the size of the lesion that you would expect. So we did this study that involved all the usual sort of parameters. Prostates were measured between the veru and the bladder neck, and that was the expected range. It's a 20 French silicon catheter, and it's just a normal off-the-shelf catheter which has been modified. So you could see if it did work, it could be an extremely effective and safe and cheap way of going about things. 70 degrees for in 60 seconds and held for 3 minutes. And rectal temperatures were monitored throughout, and all the usual data. So we treated 8 patients, some general, some spinal, no complications, well tolerated. They all went home with a Foley on the same day. When the catheters were removed at 5 days, 6 of the 8 had to carry on with self-catheterisation because of the edema and so forth and inflammation. There was a reduction in volume. Post-void residual didn't change from baseline. And these were the early results. That's the IPSS, the usual 50% decline, and quality of life score much the same. As I say, it could be any of these devices that we're using today, these minimally invasive devices. Another Qmax values, 5 mils per second on average, sustained out at 6 months, and that's the PSA values a little bit. Adverse events was really only inflammation, and always resolved within 3 or 4 weeks. And so in 2004, we presented these data and were saying these sorts of things about this product, but we did carry on following them. And unfortunately, the results at 12 months, they were almost back to normal for every parameter. And so Eric Cosman just decided that urology was not for him, took his device and left. We never saw him again, and never published the data. So it's hard to know if that could have been something or not, but we never got a chance to find out. So moving on to some of the current stents. The ZenFlow spring system is a stent which has been it's probably been studied now for 5 years. They've just finished recruiting and most of the follow-up for the pivotal study, and we were involved in the phase 2 studies. That's the shape of the device. It's sort of an unusual device, and because it's an unusual device, one of the problems with it is the deployment, and I'll show you a picture shortly of how that works. Basically, there is a handpiece, and you extrude the device, and it comes out, it worms its way out in strange angles, goes out at right angles to start off with, and comes back in. So you can actually deploy it and get all the bits of wire in between the bladder neck and the veru, but it very rarely looks like that picture on the right. So we were involved in what was called the ZEST EU study, and the BREEZE study is the name of their FDA study, which has just been completed. So we followed them. That they will be followed out to 5 years. We're up to we've just finished completed data for 3 years, and there were 68 patients in the study that we were part of, out to 38 at 12 months. And procedural success is a relative thing, and it's to do with the thing being in there at the end of the case and waiting and seeing how things developed, which was really the extent of it for most of them. But very few patients that you couldn't put it in. There were a couple that it was just physically impossible and had to be removed at the time. But once again, you get that usual, 53.6% reduction. That's at 6 months, holding at 50% out to 12 months. Looks just like all the others. Quality of life score, same. And flow rates, just the usual 3 or 4 mils per second. And those 50 to 60% improvements in all those various things. Safety becomes a little bit more interesting. And as you can see, the numbers on the right there, incontinence, pain, retention, so on and so forth. Eight of them had to be removed. I removed a couple of them. And the holmium laser is excellent for removing stents. You can really chop them up and bring them out piecemeal, because the laser cuts through very nicely through nitinol, which is lucky. So you could always convert them to a HOLEP if you needed to. And this is basically what the device looks like. You can see the stent is withdrawn into the shaft. You seat the stent with the balloon up against the bladder neck, and then this goes through that bespoke flexible cystoscope, and then out it comes. And hopefully that'll play. Will it play? Let's press it again. Yeah. So you get the idea. See that? So we're in there. We're in the fossa. You see, here it comes. It's just gone that way. It's coming back. Yeah. So one of the struts is out. It's jerky too. Oh, there we are. Out. Anyway, you'll be seeing this. The reps will be trying to sell you this very shortly. Oh, yeah, so that's not a bad one. That's quite a good one. Yeah. So, yeah, the BREEZE study, there's over 300 patients when they last looked, including the BREEZE study patients. And, this is data we've already seen. And that's the design of the BREEZE study, pivotal study, prospective randomised controlled trial, multiple sites, 2-to-1 randomisation with a sham control. The sham control was interesting. I think they put a catheter in the patient, and then they made noises, all the right noises that the device would make, and apparently it passed muster in terms of the analysis. So, so we'll see how that. They're very quiet though, which makes me a bit nervous, because I think they have finished follow-up, the 12-month follow-up, and as one of the investigators, you'd think if it was really looking good, they'd be trumpeting things from the heavens, but haven't heard anything yet. So it might have been an unfavourable outcome. We'll just have to see. This one looks slightly more promising. The CEO of this company, Adam Cadlick, is a urologist, and that presents its own interesting aspects because he's not averse to calling up the patients and coaching them through their IPSSs. Yeah, so urologists, it's hard for them to keep their hands off. Yeah, but obviously for the FDA study, he's going to have to be a mile away from it, and I'm sure that'll be okay. But this is another nitinol stent, and the beauty about this one is you either grab it with a proprietary hook or a grasping forceps, and you pull it back into any cystoscope. You can use either Storz or Olympus, or you can use the disposable ones, and then you just deploy it by basically pushing it in as you pull the scope out, and hopefully it winds up where you want it to wind up. So it is really off the shelf, and I suspect the IP is really just to do with the design and the material and the machinery, because you would think that it'd be very easy to knock off something like this. But the whole idea is no catheter, and can be removed quite routinely in an outpatient environment if needs be. So there were 3 centres for this study. There was 2 Mexican sites, us and Peter Chin in Australia. And this was the phase 2 study. That they did the phase 1 study in Panama, I think. This is pretty standard. 39 patients, and prostate volumes, prostate length. You can't have them too short or too long. They only had 2 sizes of stent for a start, but now they've got 3, and you can actually fit most prostates, but no median lobes, of course. And most of them were done in the clinic just under local anaesthesia, and I can vouch for the fact that is definitely possible with this device. So it could conceivably be that the patient comes in, they don't want to have their drugs, and they're quite happy to accept a lesser result, and you reach in the cupboard, grab this thing, withdraw it into your scope, put the scope in, put it in the patient walks out. That's exactly what happened to 3 or 4 of the patients that we were involved with. Now, Adam will be looking for sites, so you should put your hand up and see if you can take part, because this one probably will survive. I think it's from a user's point of view, I think it was okay. And there won't be any sites in Australia and New Zealand. He wants all US sites, so this could be an opportunity to take part. And implantation was successful in all the patients. We did have a little bit of a problem with his proprietary tool for in the first couple of cases, but got around that just by using normal cystoscopic graspers, and worked perfectly well. And there you can see it at the base of the bladder on CT and on ultrasound. You can see it out to the right there. And IPSS, there's the usual 50%. So long as you get that 50%, you're okay, and well tolerated, and no change in ejaculatory or sexual function. But interestingly, Adam wouldn't give me the flow data, and so I suspect the flows probably weren't much better. But at least you got an improvement in the IPSS scores, and so the patients should be happy symptomatically. But yeah, that's always a bit mysterious. Third stent. This is an interesting one because it's a Israeli company, and they were proposing this device. I think I first came across them 2018, and it involved a circular incision with cautery in the prostate, and then the ring that they were calling it the clear ring at that point is then inserted into that groove to give you the result at the bottom there. But they've given up on the previous device, which was called the clear ring device, and now they've got this the Omega system, and this basically cauterizes and then just places the stent. It doesn't try to do a big circular loop, so they've made it a whole lot simpler. So we'll see. We've implanted 2 patients, and we have more coming. One was successful, the other one is ready for his HOLEP sometime soon, and the stent is sticking in his bladder. So we're 50-50 so far. Now, this is an interesting one because it started out well and then finished badly. The Prostafix device, this is water electrolysis. So we're using radio frequency in a number of different ways here. This is a Singaporean company or an Australian company. I'm not exactly sure where headquarters are, but those of you who know Thane Larson, he's one of the major shareholders. You know, he was at the Mayo Clinic. Do you remember Thane? Yeah. And this was the original device. You can see on that bottom diagram that there's 4 little tines that have come out below the catheter, and essentially 2 go into each lobe of the prostate, and then you deliver the electric charge, 36 coulombs, into each lobe, and it works by electrolysis. In other words, you get quite big pH changes. So it's heat-free. There's no heat, unlike tuna or something that heats the prostate. So this is an electrolysis device. And these were the early results. 2 sites in Singapore and us, 49 participants, and all the usual primary and secondary endpoints. So 46 were actively treated, and they got their 6.5 points in terms of the improvement from baseline to 3 months. And that's a graph of the IPSS scores. And 85% of them didn't require a catheter. They went home without a catheter and stayed catheter-free. A 9.5 increase in flow rates, and so some pretty reasonable and pretty above average results. MRIs were done in 14 of the patients just to show that, first of all, there was a necrotic lesion formed, and secondly, to show that by 3 months that the necrotic lesion had resolved once the inflammation things had settled. So 45% patients had AEs, most were unrelated, and they were pretty much all pretty mild. So that was fine. So that worked reasonably well. And then they came to us with the new device, and this was supposed to fit over a catheter, just a normal Foley catheter, though it was a bespoke catheter that was a bit shorter. And unfortunately, it was just a fraction too big for the special catheters that they'd had made. So with great difficulty, we were able to put it into the catheter and seat it, and then we deployed those tines into the prostate, but then couldn't get the device out. And the guy was sitting there quite happy. He was perfectly happy, and we were sort of subtly trying to. But anyway, to cut a long story short, it broke internally, but it broke in such a way that it was still connected, and we were able to. Once it broke, we were able to have it rotate, and then we were able to gradually get it out, but we weren't exactly sure where the tines wound up, and where the needs work is what I and they're still they're back at the drawing board now, and they should have just made sure things fit. They came along with a catheter that fitted perfectly well over the device, but it only fitted perfectly well because they'd dilated it up about 50 times, and when they showed it to various people, and so it was, it worked quite well just on the bench. And lastly is the new version of HOLEP, they hope. This is a company called Andromeda, and they're based in Silicon Valley, and they've got big flash new offices, and they are developing and have developed a robot to do transurethral HOLEP. It's a bespoke arm. It's an off-the-shelf arm made by a company that's well known in the foodstuffs industry called Kuka, Kuka. I think they're from the Netherlands. I think they're from. But anyway, so they just buy that robotic arm, and they have the control box and the software and the touch screen. That's all theirs. They call it the Beacon platform, and I've tried this a couple of times. First at UCI earlier in the year at a HOLEP course that we were doing, and secondly at the AUA, and it's certainly way better between the two of those experiences, and we're just going through the ethics process now. Hopefully that'll be any day, and we're due to do the first case in a few weeks' time, and they're hoping to enrol 40 to 50 patients, 3 sites in New Zealand. I'm not sure how many in Chile, but don't ask me why Chile, but it's Chile. And this might well be the next phase for HOLEP, in the same way as Da Vinci is a sort of a master-slave type thing. That's all this is, and all you're doing on the touch screen is driving exactly the same instruments as you normally use, but doing it on a touch screen in the comfort of your your booth or wherever you're sitting to do it. And so this is what they're calling Generation 1, and they want to call it ROLEP. That sounds a wee bit too much like Rolex, and I'm not thinking of watches here, but we'll see if that sticks. And then they're hoping to use, and they're getting really quite advanced with autonomous aspects. I think they've logged in over 500 cases, and they've fed it into the AI programs to get to the thing to learn how to do HOLEPs, and we'll see how that goes, and see how the autonomous aspect, because HOLEP does in some ways lend itself to an autonomous rather than urologist controlled thing. So I'm not entirely sure I'm happy with that, but let's see. And that's the timeline they think they're working to. I'm pretty sure it'll be nothing like that. Anyway, thank you.
Questions? Anybody have questions? I just wonder, like, every time you get this new device, like, do you have palpitations when they want you to test it?
Anything that looks obviously dangerous, we turn down. I mean, the one that went really badly, we'd had such good experience with the first device, and I was thinking that would solve all their problems, but they just got the sizing wrong, and it wound up with a bad patient situation. And yeah, it was probably the one that I least expected to go wrong.
I was just going to say, perhaps you can comment. So for the people in the audience who aren't big BPHers, my sense on the stents is that it's going to be less about the stent than it is going to be about the delivery device, and how easy it is, whether it's coming with its own proprietary disposable cystoscope, whether it's coming, like you said, with Rivermark that can be used with any scope, whether it truly can be done at a bladder surveillance cysto, where you notice that the patient seems to be having a lot of bladder changes. You ask them, they say they have voiding issues, and you can say, hey, I can do this right here, right now. To me, that's where the game changer really comes. And so you've now tried a bunch of the delivery devices. Do you have thoughts about that?
Well, that's why the Rivermark stent is probably one that you might want to get involved in, if you can, in terms of being a site for the FDA study, because it has real promise to achieve exactly those things that you said. Just an off-the-shelf, in the office, just a decision that you and the patient make, and away you go. But as I say, so long as Adam keeps his hands off your data, you'll be fine.
Peter, thank you. That was a fantastic talk. And you are a superb and experienced clinical trialist of many years. I'm wondering, can you speak to the placebo effect that you've perhaps observed with some of these devices over the years? I seem to recall it being pretty robustly demonstrated in the Urolift trial, as I recall.
Now, I saw you collect a certificate before for attending yesterday. I spoke at length about the placebo effect in my talk yesterday, and you've just outed yourself as having not been there, Kelly. Yes, but and I showed Chuck's. Kelly and I, we had a debate in Queensland one time, and what was it about? I forget what the topic was.
It was Holep versus Robotics Simple, I think.
Yeah.
Oh, Greenlight. Holep versus
It started
Greenlight.
out really friendly like, and then it sort of deteriorated.
It was friendly until you compared me to a Muppet, as I recall.
Surely not. No. Yeah, no, but there is a big instrument placebo effect. Yeah. Thank you.
Hey, Peter. That was a wonderful summary, especially coming from where I sit. The question I have for you is, there's a number of these stents in various stages of development, as you pointed out, and at some point somebody's going to get 510(k) clearance. But how do you see these stents being used clinically? What's the target patient population? Where will they fit in with respect to the other treatments that we have for, the myriad of treatments that we have for BPH?
Yeah, there's a lot of positioning going on. I'm sure you're aware of Dean Elterman's True Mist designation, which is the off-the-shelf, in the clinic, all your own tools type designation. And the stents that are able to fulfill those criteria are the ones that are going to be most used. Whether or not they should be used is another matter. And if you're doing something that's very effective already, like HOLEP, I don't see myself using them very often in clinical practice at all. But they might be a way of getting people catheter-free who are never going to be candidates for surgery. I mean, there's various scenarios you can see a stent being useful, but if they have any of the problems that the Urolume stent had with the incrustations and all those other horrible things, so far so good. I think the composition is such that these ones aren't quite as prone. But Nirvana's in there somewhere, but I don't think the stent mark is going to be. It's going to be for in some jurisdictions, like I suspect the US, they'll be used very commonly as part of a 2 or 3 step TERP. But in New Zealand, they're never going to be used. Yeah.
I was going to ask Dr. Morton, how do you choose the one that gets the lucky exit?
Because you'll be
how
doing
long
the
does
choosing.
that take?
Yeah.
Can we save that for when I give my talk later?
Yes, we can.
Dr. Gilling, I had to Google how many people lived in New Zealand, and it's about 5 million, 5.2.
Yeah, 5.2, something like that.
So you say, okay, minus 50% who are women, then we're looking at a fairly small population that really have significant BPH problems. I'm just,
What you're really asking is
What
how
am
many
I asking is-
urologists are there in New Zealand?
okay, I can ask you that question too.
About
My other
60.
is I'm impressed by all these studies that you're doing in New Zealand with a relatively smaller population. And I guess I'm commenting more about the trust that the New Zealanders have in their health system. I'm just shocked that you could come up to a patient and say, I don't know how this works, but would you be willing to try it?
Yeah.
When there are so many other treatments that really work.
Yeah, well, we've been doing
you
these studies for 30 years, and our hit rate's about, if we're actively enrolling into a study and a patient seems to be eligible, about 30% of patients will agree to take part in a study. And that's a similar number to other sites that do this type of research around the place. So about 30% of the eligible patients that we would approach will take part. But we're not, New Zealand isn't peculiar in that way. That 30% is pretty similar to others. Yeah.
Thank you.